An over-mature cataract with moderately dilated pupil, the capsular bag is tense. A temporal tunnel is created starting from the anterior sclera across the limbus into the cornea. Trypan blue staining of the anterior capsule. Visco is infused into the eye so that the anterior chamber becomes a little deep. Tunnel floor entry technique, wherein the tunnel remains closed during the cystotome. The tip of the cystotome perforates the floor of the tunnel at the limbus to enter into the anterior chamber. The advantage is, in a case like this, there is no continuous leaking of the viscoelastic out of the anterior chamber, which makes the chamber shallower. I'm trying to rotate the nucleus and disturb the cortex so that much of the cortex is aspirated before the rhexis is enlarged. I could get a good continuous rotation of the nucleus, epinucleus, cortex mass. The loose cortex from the front of the nucleus and epinucleus is aspirated as much as it's possible to make the capsular bag less tense. The inner aspect of the tunnel only is enlarged. Outside remains stable, standard, but inside is enlarged. I'm going to enlarge the capsular opening by using a Utrata forceps. It's ideal to make it as large as the pupil allows, taking care that the capsulotomy does not run off to the periphery. AC is maintained with dispersive viscoelastic. The nucleus is rotated in the capsular bag and is lifted up out of the capsular bag by manual rotation. This puts least amount of stress on the zonules. That's a hard nucleus. I'm supported by a mini vectis. I'm trying to bisect it by routine ways. Sometimes it breaks. When it is not making any headway, then I'm going to use a cystotome, which is on the table all the time. And that cystotome tip is used with the supporting the nucleus on the behind. The nucleus is not lifted up so that endothelium is not damaged. The cystotome is mounted on a 2 ml syringe with visco, which is continuously being injected in front of the nucleus so that accidental damage to the endothelium is avoided. It's brought into the surface. You get into the mass of the nucleus and then pull it out. The sharp tip can easily remove the nucleus out of the capsule, the anterior chamber. The AC is thoroughly aspirated. Some amount of clear cortex will invariably be there in the periphery near the equator, which has to be specifically looked at and aspirated all around using Simcoe cannulas. Right and left J-shaped cannulas are used for subincisional cortex, as there are no side ports needed for the surgery. IOL is implanted, it's centered, and then it's rotated in such a way that the haptic optic junction lies in the horizontal meridian. This will reduce the possibility of the dysphotopsia the patient may have at the later stages. Entire visco from the angle region and from the under the endothelium and in the capsular bag is aspirated. As the tunnel is not disfigured, there is no need to hydrate the tunnel. AC pressure is elevated to normal levels, and you see that's the end of surgery. Thank you.